Hello everyone, this is your in-service training for BLS Cath Lab activation, and we're going to standardize a few processes, and I think that it's important for both our BLS and ALS providers to go through this training. I think that both can derive some benefit. These are your objectives. You can review them if you like. So why BLS Cath Lab activation? Well, we do know that the LifePak 15 does have fairly high sensitivity and specificity for detecting that based on the computer interpretation algorithm that it uses. So the algorithm is pretty good, but it's not perfect, which is why we still want our ALS providers to perform an overread and make those tough decisions. But for our BLS providers that are not trained on interpreting a 12-lead EKG, this is the second best thing. And actually, hospitals are now using their nurses at triage to obtain a 12-lead and make decisions based on the computer interpretive statement. So why can't our BLS providers do that? Now, another reason that we want to incorporate this into our system is because just because a patient is having chest pain, if all of our ALS units are out, it doesn't mean that one patient needs it and the other doesn't. So we shouldn't be performing it just when we have an ALS unit on the truck responding to a chest pain. If all of our ALS units are out and all we have is a BLS unit, then that patient can still receive early intervention just as if an ALS provider was there. So here is the sensitivity and specificity for the LifePak 15. And now the sensitivity, just ask, is the disease present? So if you obtain a 12 lead, what percentage or how often is the monitor likely to detect that the patient is having an MI? The specificity ask, is the disease not present? So if the computer says that the patient is not having an STEMI, or if it does not give that message, how likely is it to actually not be present? And this is kind of confusing, but essentially, if the computer says that the patient is having an MI, then most likely they are. Now, there are causes of false positives, and we'll go over at least one of those. So what are the indications for obtaining a 12 lead? I like to say it's a patient that's having pain anywhere from the nose to the navel, front or back. We do know that about 25% of patients don't have or were not recognized as having ACS on presentation. 1/4 of patients don't even report chest discomfort, and this is especially true in our elderly population, our diabetics, and patients that had a female gender on at birth. They are susceptible to having MIs without having classic signs and symptoms of cardiac ischemia. So we want to have a low threshold to obtain 12-lead EKGs on nearly every patient with vague symptoms. And the point of entry protocol, or the activation procedure, outlines this pretty thoroughly. We want to consider atypical presentation. So if they're having abdominal pain, neck pain, arm pain, jaw pain, dyspnea that you can't explain, weakness, or if they're diaphoretic, these can be isolated symptoms in the female or elderly or aging population. So what do? You show up on scene. You've got a patient with obvious signs or symptoms, or maybe even vague symptoms. We've had a lot of cases of patients with very vague symptoms, and luckily the paramedic had a low threshold to obtain a 12-lead EKG, and they picked it up. This is not something that we should be missing. So you want to get a stat 12 lead with the first set of vital signs. You walk in, one person's assessing the patient, obtaining demographics and history and physical. The other setting the monitor down, turning it on, and attaching the leads and the other monitoring equipment. Now, if you're a BLS provider, once that 12 lead prints out, you look for this statement that it meets ST elevation MI criteria. If not, then you continue assessing the patient, repeat the 12 lead, and consider other differentials. If you're an ALS patient, not much has changed. Now, you do need 2 computer interpretive statements that read meets ST elevation MI criteria, and we'll go over why. You want to keep your scene time short, so you want to rapidly extricate the patient, and you have to notify the receiving facility of a stimulant as soon as possible. If you're a BLS unit, you still call in a stimulant as usual. But when you call in your actual radio report, not the one that you're, not like you would if you're just going through dispatch to advise them of a STEMI, when you call in your radio report, you say, this is a BLS unit. We request a physician rendezvous or meet us in the ED for physician overread. The facility may or may not want to do that. But this is something that we're going to ask them if they want to do. When it comes to transport, we will transport to the closest PCI facility unless the patient is unstable. If they're rapidly decompensating in front of you, then you might want to take them to the closest facility. If ALS is available, ask them to intercept you en route. However, you don't want to be sitting on scene waiting for them. If they can meet you on the way, fine. But if you are ahead of them and you have to stop and wait, then don't wait. Continue on. So we really need to pay attention to artifact, because artifact is notorious for triggering the acute MI message. And this is one reason you need 2 consecutive 12 leads that give the acute MI message. Now, we need to be able to scan the EKG and look for anything that appears to be artifact. If you look at lead V3, you'll see that the baseline is almost flat. There's some undulations in between the complexes. All right, but if you look at V2, you'll see a lot of artifact. Now, you can localize which EKG lead is the culprit that's causing the artifact, but I don't know that this is absolutely necessary. If it's the leads that go around the chest, so your precordial leads, then that's pretty simple. If V2 is causing the artifact, then you'll see that and you can troubleshoot V2. But if it's the limb leads, then it's not too difficult to just quickly inspect all limb leads for a loose electrode or a disconnected electrode. Do you see any artifact on this EKG? And if you're a BLS provider and you're not sure, after you scan each lead, so if you look at lead 1, 2, 3, AVL, AVF, V1, V2, V3, all the way to V6, and you can't confidently say whether or not this is a clean tracing and whether or not this would be acceptable for whether or not, if the computer gave you the acute MI message, if you could say that this message is not likely to be triggered by artifact, then I want you to take extra time and I want you to compare the baseline. So if you look at each lead and you're not sure, if you can't confidently say whether or not artifact is present or not, then I want you to come to me or I want you to talk to your paramedic partner and ask them to show you what a clean EKG looks like. But if you look in between the complexes, you can see a pretty clean baseline without much artifact. So the line is relatively flat and relatively straight. And if you compare it to this one in the previous slide, you can clearly see the difference in what a EKG looks like with artifact and what one looks like without. Here's another tracing that is clean, and it's much easier to tell that this is a good tracing because the complexes are further apart, so there's not much artifact on this EKG. And if the computer said that it was an acute MI, then you could be fairly confident that it's not caused by artifact. There are multiple causes of artifact, and there are a lot of things that you can do to minimize artifact. Now, these are just a few causes. You can see in the top, you can see respiration artifact, which is just a wavy. You can see the complexes are just wavy. Then there's the patient movement and the transport artifact. So again, you are going to need 2 EKGs that give the computer interpretive statement meets ST elevation MI criteria, 2 without artifact, and you need 2 contiguous or 2 consecutive ST elevation MI messages. So how do we reduce artifact? Well, first, if we have a patient that's sitting upright or that's ambulatory, we need to lay them flat or put them in a reclined position so that they are not supporting themselves with their limbs, and it decreases their ability to move. Secondly, where do we place the limb leads? We can strategically place the limb leads in a method that helps reduce artifact. The right arm lead can go on the upper arm or on the deltoid. The left arm lead can go on the upper arm or the deltoid. Do not shove the leads down through the shirt to get them on the chest. They should go on the limbs, but you can place them proximal. So if the patient has a t-shirt on, this is very easy because you can just pull up the sleeve a little bit and still have room for your blood pressure cuff below that. Now for the lower extremity leads, they don't have to go on the lower extremity. They can go anywhere on the lower extremity, but then you increase the chance of having artifact. They can go on the lower abdomen. So the right arm lead can go on the lower abdomen, medial or lateral to the umbilicus, and the left leg lead can go on the lower abdomen, just lateral to the umbilicus. Now, there is good data and good evidence for using this lead placement method. Kahn et al. Found that the new method is faultless and provides better quality ECGs, no recalls, and without risk for misinterpretation. You don't have to worry about removing the leg garment, and the forearms are free for IV access. This is a good method. It's validated, and I think that it is a method that we should adopt across the board and standardize for obtaining 12 leads at Jessamine County. Now, what are you going to do if you have to place the precordial leads? Again, I don't want you going over the collar of the shirt to place any lead because that increases your chance of artifact, and it's easy for the leads to just get pulled off. First of all, if the patient has a shirt, well, if you can do so while maintaining the patient's dignity, then just remove the shirt. If not, then you can go underneath it. But you want the leads to be able to lay it out neatly, as straight as possible, to minimize artifact. Now, where do we place the precordial leads? Well, V1 and V2 should be at the fourth intercostal space, which means that it should be almost, but not quite, almost at the level of the nipples. This is much lower than most people are accustomed to placing these leads. And this is something that's not new. This is how we should have always been doing it. It's just that people see other people placing V1 and V2 up towards the clavicles and then realize, and then that becomes the new standard. So we need to revert back to the right way of doing things, which is to place V1 and V2 at the fourth intercostal space. Then I like to place V4 at the fifth intercostal space, mid-clavicular line, so right underneath the nipple. And then V3 can go right in between V2 and V4. You should be able to draw a line straight from V2 to V4 and place V3 right in between that. And then I like to place V6 at the fifth intercostal space anterior axillary line, so it just goes straight across right under the axilla at the fifth intercostal space. And then V5 can go directly between V4 and V6. So let's say you get the acute MI message. The computer says it meets ST elevation MI criteria. First thing you should do is place the pads. Place the anterior pad, the lateral pad, and connect them to the monitor. That is our standard and that is our expectation, because if the patient goes unresponsive and goes into an abnormal rhythm, it decreases the amount of time that it takes to apply the defibrillation. So in summary, obtain an EKG as soon as possible. If you get the acute MI message, apply pads and rapidly extricate the patient. You'll immediately notify the receiving center of a STEMI alert, administer aspirin, plus or minus nitro, depending on the blood pressure and depending on whether or not the patient's prescribed it. If you're a BLS provider, you can request ALS intercept, but you don't want to wait around too long. If the patient's unstable and ALS is not available, then transport to the closest facility and they will figure it out from there. As always, please let me know if you have any questions, and I hope you all are excited to maybe use this protocol.